Sammy, I think you should be co-host now. Cool.
Yeah. So for the first aliquot, we have a 43-year-old male patient that presents with disseminated ulcers in the perianal region and the oral region. And maybe I can stop there or give more information about the HPI.
I think why don't you go ahead and give us some more information about the HPI, and we'll open it up to the group. For those of you who have thoughts, please do feel free to share them in the chat. We'll sort of think through the aliquot together after Gabrielle gives us the HPI.
So this disease started 3 months before. And in 3 months, the patient got his second dose of Pfizer, and then he developed rhinorrhea, myalgias, arthralgias, and headache. And also he reported fevers. So he took some acetaminophen to relieve, and the symptoms relieved. 2 weeks before presentation, the patient referred odinophagia. He had difficulty with solid and liquid food ingestion. And also he referred rhinorrhea continued, but now it had a bloody expectoration. It was a bloody secretion. And also he continued with coughs and also hoarseness. So he went to the emergency department and they diagnosed bronchiectasis, and it was treated with antibiotics, tranexamic acid, and some opiates for the pain, because he also reported a lot of pain in the pharynx. 5 days before, the symptoms got worse, and he developed some painful lesions in the feet and also in the hands that progressed to ulcers, and the ulcers were bloody. Also, he then noticed painful in defecating, and he saw them, and he saw in that perianal region bloody ulcers, and also oral ulcers. Finally, he also reports back pain of 5 out of 10 of intensity. During all the course of the disease, he has lost 10 kilograms.
All right.
Let me know if there's any information, Shima, that you didn't get.
Right.
But the chief complaint is right with perianal and oral region?
Yeah, disseminated ulcers. That will
okay, great. Thank you.
Amazing. Thank you so much, Gabrielle. I think what this really highlights is how the chief concern that we often get when somebody walks into our clinic, into the emergency room, or into the hospital, it may be all that we have, like it may capture completely the problem that we have to solve, or it may just be the tip of the iceberg in terms of the problem that we have to solve. And I think what this HPI really highlights for me is how the oral ulcers and the perianal ulcers, while potentially potent and unique findings that may carry a lot of diagnostic weight, they are by no means the complete story. Because as you walk through this HPI, we got a much clearer picture of an illness that is not only limited to these 2 findings of oral ulcers and perianal ulcers, but one that involves many other organ systems and has a much different tempo than what we may have originally anticipated. I see some already incredible thoughts flying in the chat. Maybe I can come to you, AMK, first to sort of mention, to sort of talk through how you're integrating these various organ systems that seem to be involved, which include the respiratory tract, the GI tract, as well as the skin.
want to say that kind of like the more organ systems are involved, the more you think about if something like involving the blood vessels could be involved, like a vasculitis or something like that, or an autoimmune disease that can affect the whole body. So definitely kind of considering the range of manifestations, but these are also parts of the body that have a lot of like mucosal tissue and surface area too. And so I'm definitely trying to integrate all that together. So I'm trying to think really broadly right now, thinking about autoimmune causes, thinking about vasculitides, and then infectious mimics of vasculitides. And then I think Fernand mentioned a drug reaction, which is also possible. And then like kind of the ID problem list as well, and then establishing the immune status and kind of sexual history to help work through that. So those are just some initial thoughts I had.
Awesome. Thanks so much, AMK. And then I'm seeing a number of people mention sort of both the importance of understanding what infections could be involved, but also what infections this individual may be potentially at risk for. Alec, could I come to you to share a little bit more about how I see you mentioning how this individual's HIV status will be helpful. Could you share a little bit more about how you're sort of integrating this individual's immune status into the way that you're approaching these initial symptoms that we have?
Sure. Yeah. I mean, I think obviously a lot going on here, and I think frequently because of the way we try to diagnose people, and it's overall fairly young patient, we like to try and be parsimonious and see if these things are linked. But I think the HIV status is very important because patients can have as many diseases as they want, and when their immune system doesn't work, particularly in the setting of HIV, multiple things can be going on. And so I think it just challenges you to think about this, because maybe if the patient is HIV positive, maybe the oral ulcers and the dysphagia are related to CMV, and then he has a total other secondary process explaining some of the other things, and maybe the rash is syphilis. And it's I think it just helps to broaden the differential, although parsimony is important, and important to think about, I should say. HIV sort of just blows that open.
I love it. I love it. Thank you so much, Alec. I think this is fantastic. And I think one other thing that we're going to have to grapple with here in the HPI is we have this history that Gabrielle gave us that this individual received a Pfizer vaccine 3 months before. There was sort of a brief period of this individual having some symptoms, and then those symptoms went away, and now we're seeing sort of 2 weeks of this progressive illness. And I think oftentimes we will see that there may be some temporal marker in an individual's HPI that we feel like we have to integrate into the problem representation. And I think, for example, one of the places where this frequently comes up is somebody says, oh, I developed gastrointestinal symptoms after I had this meal. And we're challenged to decide, is that meal on the hook for their symptoms, or are these symptoms actually true and unrelated to this temporal marker? And I think really what we have to do is actually probably work up 2 parallel tracks, because our brains will always want to identify the start of a concerning event with something that happens to us. And so it might be able to say, oh, all of this started after the individual received the vaccine, but in reality, they may actually be completely two unrelated events. And so we can go down one diagnostic reasoning pathway where we're considering whether or not the vaccine is on the hook, but then we also have to probably have our reasoning pathway where we're going to say, actually, the vaccine has nothing to do with this clinical presentation, which from a probabilistic reasoning perspective is probably much more likely. And so I think as we go forward here, right, we're going to have to now do the cognitive work of trying to characterize what type of disease syndrome this is, right? We have this sort of progressive escalating disease that's characterized by pulmonary involvement, what seems like esophageal, oral, and rectal involvement, but then also getting a better sense of how we're gonna prioritize whether this is an infectious etiology, an autoimmune etiology, or a malignant etiology. And I think all of these features that both AMK and Alec have mentioned, are we seeing features of something like a small vessel vasculitis or a medium vessel vasculitis, or are we seeing features that may make us think that this individual is at increased risk for a disseminated infection like underlying immunocompromise will be key. But I think right now it's difficult to make a ton of progress in terms of characterizing possible diagnoses, because we still have to define the syndrome with a little bit more clarity before we can start to narrow things in. So Gabrielle, I'll turn it back to you to sort of take us further forward. Maybe you can take us through the background of the exam, and then if you'd like to, any labs that feel important.
Wow, quite good points, guys, and also in the chat, really interesting. So for the past medical history, he had pulmonary TB 10 years ago, and he received treatment for 6 months. He states that he completes all the treatment, and also he has bronchospasm with chronic cough 3 years ago, that he was treated with, air supplementations, but he doesn't remember the name. Actually, there were some home medications. He did not have any surgery. He doesn't smoke, doesn't drink alcohol. In family history, his little brother has skin cancer, but he can't remember what type of cancer. So for the physical exam, the arterial pressure was elevated, or 170/80, heart rate 115, respiratory rate 25, the temperature 39, and the saturation of oxygen 94%. So generally, he is awake, lucid, and oriented in time, space, and person. In the pulmonary exam, the lung sounds were decreased, and also it was noted wheezings bilaterally. In the cardiovascular exam, it was tachycardic, but it has a good rhythm, no murmurs. In abdominal exam was normal, but he refers pain in the left flank. No hepatomegaly or splenomegaly was detected. So I have some pictures of the hands and the perianal region of the ulcers, if you want to see.
It would be really, really, really wonderful to see.
Mm-hmm. Yes. So these are the ulcers in the hand. They were bilaterally and they were hemorrhagic. And for example, these are the ulcers of the perianal region. They were also bloody, and they have a well demarcated margin. Yes, you can see both also some ulcers here.
Amazing. Thank you, Gabrielle. All right. So I'm seeing a number of really important comments on some of the information that we got from both the past medical history, but also from the physical exam here. I see one hypothesis coming out, which is sort of how are we potentially integrating this history of pulmonary tuberculosis and the fact that it was treated into the discussion here. And then there's the other thread, which is like, okay, how can we now better start to characterize these physical exam findings that we're potentially seeing here. Fernanda, can I maybe come to you to share a little bit more about how you're thinking about the pulmonary TB history at this point in time?
Hi guys, it's been a while. Pulmonary TB, I mean, could happen in some high-risk endemic areas for no specific reason. So it should not definitely make me worried about underlying immunosuppression. I mean, some unlucky people do not clear it and develop the disease. So it's still a possibility in endemic regions. Although I have to keep in my mind that it might suggest an underlying cellular dysfunction such as HIV or other disorders such as cancer, lymphoma. Um, on the other hand, I do not know if these bronchiectasis patient are idiopathic. They just developed over time because some patients are prone to develop chronic dilation of their bronchi, or it's something related to damage from TB. It probably is not related to the current problem because the current problem seemed to have developed over the last 3 months, and it takes much more than this to develop bronchiectasis.
Amazing. Thank you so much. Thank you so much for sharing that. I think it's a great point that regardless of whether or not there was some degree of underlying immunocompromise that led to the development of pulmonary tuberculosis, there also is this potential that maybe we could be seeing a recurrence of the disease here in this setting. And then maybe I can come back. I'm scrolling through to see if there's anybody who is able to share a little bit more about some of these exam findings that we have here. I know Angelita is in front of patients, but again has brought up a really, really important point about sort of how we can potentially integrate the hands and the feet findings. And I think I've seen a number of individuals mention the possibility of there being a small or a medium vessel that vasculitis. Jasimran, are you in a place where you can unmute and share a little bit more about how you're thinking about the exam findings?
Oh, hello, everyone. First, I second the thoughts regarding Fernand, how he tried to communicate the TB history in this context. The main thing that I was thinking is that any bacteria of TB can be latent in the body. And when the immune status again suppresses because of some other disease, that can again reactivate and present. And I have seen like skin presentations, just the skin presentations of TB as well in India. Like just the Gabriel shows us the lesions that were blue. So I have seen the varicose lesions in TB. There are lupus vulgaris, tubercular abscesses, tubercular cutis inflammatory, cutis manifestations. So it could be the reactivation of tuberculosis along with some other autoimmune disease, and like both are presenting simultaneously. So that was just one thought regarding the skin lesions. But we also have the weight loss, fever, cough that do support the reactivation of tuberculosis. So that was my thought regarding the tuberculosis.
Thank you so much, Simran. I think it's really, I am feeling so energized hearing the ways in which our reasoning is sort of starting to coalesce around two potential diagnostic hypotheses based on the information that we have. We have sort of one hypothesis is that this is an individual who for some reason has developed a disseminated infection that is characterized by multi-system involvement. And we're saying that the most likely culprit for that disseminated infection is the infection that we know this individual has previously had in the setting of a recurrence or new dissemination of tuberculosis. And I'm hearing the sort of ways in which everybody is integrating and saying, well, gosh, all of these findings that we have, the prior history of pulmonary TB that we have heard is treated, this new development of pulmonary symptoms, indolent subacute inflammatory symptoms, as well as cutaneous and gastrointestinal involvement is completely compatible with a recurrence or a new diagnosis of disseminated TB. And then I'm hearing the other diagnostic pathway, which is that this is somebody who is actually having a new diagnosis of some sort of multi-system autoinflammatory disease. And we're starting to characterize that multi-system autoinflammatory disease as something that could be a small vessel vasculitis or a medium vessel vasculitis. I saw the excellent question in the chat about asking about testicular pain, which can be a common but oftentimes underappreciated finding in somebody who might have polyarteritis nodosa. And so it's a great thought as we're starting to sort of unpack some of those threads here. I think a couple things that at least are data points that are somewhat challenging here is what do we make of this individual's hypertension and their very wide pulse pressure? I think whenever I see multi-system indolent inflammatory disease process that's characterized by findings that could be related to a vasculitis, right? Usually if somebody has a progressive disseminated infection, we might expect them to be a little bit hypotensive, sort of be SIRSy in nature. But when we see that there is hypertension that may not otherwise be explained by the past medical history, I start to wonder the ways in which the kidney could be on the hook, right? And if we're going to sort of overlap hypertension with our small vessel vasculitis hypothesis, we have to entertain or at least ask ourselves whether or not there could be a glomerulonephritis involved here. So taking particular care to look at not only the renal function, but also closely examine that UA, also acknowledging that a normal UA in the setting of a suspected small vessel vasculitis does not rule out GN. I recently learned that about 50% of patients who have glomerulonephritis from a small vessel vasculitis will actually have a normal urinalysis, and that we won't see CAS or dysmorphic RBCs initially up front. And so I think that is something that is at least coming into my head as maybe something that is atypical for a typical presentation of a disseminated infection, but probably doesn't carry the same diagnostic weight. So I think where we go from here is we have to further characterize the organ involvement that we can't yet see, right? We can see the cutaneous findings, and everybody here has given us a great explanation about how these are compatible potentially with a granulomatous process like a paniculitis, which we could see in tuberculosis, or with a vasculitis if we're dealing with purpuric and ulcerative lesions. But there's a number of organs that are involved that we haven't gotten a good picture of yet. We haven't gotten cross-sectional imaging of the chest. We haven't seen whether or not the GI involvement is just in the oropharynx and the rectal region, or if it actually is existing throughout the gastrointestinal tract. Acknowledging that both TB and a small or medium vessel vasculitis can present with GI ulcerations. And then I think we haven't necessarily got a sense of what other organs could be involved, for example, such as the kidney. And so I think that's where my mind is going to be tuned to as we start to unfold. What is the characteristic appearance of whatever pulmonary process may be involved? Are there other manifestations within the GI tract that are particularly helpful? And then are we going to see potential renal involvement here, which may push us more towards a small vessel vasculitis as opposed to a disseminated infection? But we'll have to see how this unfolds.
Well, what a masterclass. So continuing with the labs, okay, so we have a glucose of 164. Urea was 46 milligram per deciliter, which was normal. And the creatinine was a 0.74, which was normal. The hemoglobin was 11 grams per deciliter, which was low. The leukocytes were 2000, so they were pretty elevated. The platelets were 522. 1,000, which was normal. Eosinophils were normal. And other exams, such as C-reactive protein, was elevated, 39. The hepatic exam, the total protein were elevated at 5.8 grams per deciliter. The albumin was low to 2.3. And the liver enzymes, the AST, ALT were normal. So for the infectious workup, yeah, as was mentioned also in the chat, TB was thinked. So the acid-fast bacilli staying for sputum came back negative 3 times. The HIV ELISA was non-reactive. RPR was non-reactive too. HTLV1 was non-reactive. SARS-CoV-2 also was non-reactive. Cytomegalovirus, Epstein-Barr, also non-reactive, and hepatitis B, hepatitis C serology was negative. And I also have the CT chest image, but it has the name of the patient, so I can show them. But it shows, I will try to describe, but bilateral nodular infiltrates, and also what is called tree in batch pattern. So they were basically the findings on the chest CT. And also in the head CT, it was compatible with chronic sinusitis. And also, Jack, as you mentioned, it was important to evaluate some other organs that we cannot see in the physical exam, such as the kidney. And for the urine exam, it was shown that we noticed 10 red blood cells per field, and the 24 protein collection was high at 870 milligrams.
All right. Thank you so much, Gabrielle. This is incredibly fascinating. So just to make sure that that we got all of the labs correct, it sounds like it was a white count of 20, the hemoglobin of 11, and the platelets of 522. Normal kidney function, but this abnormal UA, and then all of the infectious studies listed there.
Exactly.
Perfect.
TB negative, HIV negative, RPR negative, cytomegalovirus, Epstein-Barr, HTLV1 negative, and hepatitis B and C negative.
All right. Well, this is an incredibly rich aliquot, because I think what it helps us do is it helps us decide where we want to prioritize our cognitive efforts. And I think where we can prioritize our cognitive efforts now is in the CT chest findings, as well as in the urinalysis findings. And I think if we talk initially about the CT chest, as well as the fact that we have these findings of chronic sinusitis, I think this sort of continues to advance both of the diagnostic pathways that we had, right? There is one pathway in which we can say that this is somebody who has a disseminated infection that may have entered the body through the airways and the respiratory tract. And that's completely compatible with something like tuberculosis or disease processes that may mimic tuberculosis, which could be our endemic fungal infections, things like cocci, histo, and blasto, as well as some atypical bacteria, things like nocardiosis and actinomycosis. But then we also have to continue to entertain the possibility that this is actually a non-infectious inflammatory syndrome, which again, I think we're having more and more evidence that is mounting that suggests that this could be a vasculitis. We ask ourselves, what is the evidence that suggests we have a vasculitis? It's that we have multi-system involvement, the findings on the UA that could be compatible with a glomerulonephritis, even though we have relatively normal renal function. And then, as we had also talked about, this sort of indolent subacute inflammatory syndrome. I think if we just double click and zoom in on the CT findings, one of the things that is tricky about this is that of the myriad of CT findings that we may have, for example, things like nodules, consolidations, ground glass opacities, the tree and bud pattern of a nodule carries the most diagnostic weight that suggests we're dealing with a airway spread of infection. What the tree and bud opacity is basically an opacification of the very small distal airways. And so tree and bud opacities are very consistent with the finding of an infectious process, because it's something that has made its way through the airways and caused these sort of distal findings. The challenge, though, is that tree and bud opacities can be from a variety of different types of infections. So bacteria can do it, mycobacteria can do it, viruses can do it, and fungal pathogens can do it. So we have to sort of rely on the tempo of the disease process here to prioritize that. And I think given the findings that we have here, something like a disseminated fungal infection, disseminated mycobacterial infection, or less likely, but certainly possible given the ulcerative lesions, a disseminated viral infection. But again, that would be quite rare in somebody who's not severely immunosuppressed, but things like HSV and VZV can have pulmonary manifestations, as well as some of these cutaneous and GI manifestations that we talked about. I think the next place we have to then ask ourselves is how do we bring the kidneys into this? And I think our glomerulonephritis framework is helpful for this, thinking about, are we dealing with a hypocomplementemic GN, which could be from something like an underlying bacteremia. I think AMK brought up the great point here of thinking about something like Bartonella or some of the other Ella organisms that can cause GN if the individual is bacteremic with that, particularly through something like a culture negative endocarditis, but then also our non-infectious causes of a hypocomplementemic disease, which could be things like lupus, like we talked about last week. There then is the post-immune category of GN, which is going to be classically our small vessel vasculitides. And then the last category of GN that we can think about is anti-GBM disease. But because we have organ involvement that is beyond the lungs and the kidneys, we can sort of take anti-GBM out of this. So I think really where these findings are sort of moving me is that we know that we're dealing with an indolent inflammatory process that could be an infection, it could be an underlying autoimmune disease like a vasculitis. The CBC findings are compatible with both. The findings of a possible glomerulonephritis is compatible with both. And then the chest imaging findings are also compatible with both. But based on the base rate of disease and some of the characteristic findings on the chest, we may have to put infection a little bit above a vasculitis, but it certainly is compatible to see a tree and bud pattern with a non-infectious etiology. And so I think I'm feeling a little bit stuck in terms of how to really advance our thinking forward a lot. I'm gonna open it up to sort of scan through the chat, but I don't know if I'll be able to actually call on anybody, but if there's anybody who wants to add their thoughts to the discussion, please feel free to do so. Feel free to unmute and share your thoughts if you'd like to add. Or maybe we can talk about where we want to go from here. I'm curious, what types of tests would people get going forward? I see things for ANA, ANCA, complements, fungal studies, a biopsy of the skin lesion. I think AMK, do you mind sharing a little bit more?
Yeah, so I'm just trying to figure out, how to get the data to get the diagnosis. And we've got a really good start to the workup. But I would just remember, just because we can't isolate the AFBs and smears doesn't mean that there's not something there. So I'm still kind of thinking about is this some sort of vasculitis or is this a vasculitis mimic? And so trying to sort that out, I want to kind of send the vasculitis evaluation, but then also be thinking about getting blood cultures. But then also, is this like some sort of culture negative endocarditis where we just didn't hear a murmur? So thinking about, do we need to get an echo as well? Send some of the different serologies for culture negative, like Q fever, Bartonella, brucella, things like that. And then also see if there's a good lesion with Derm's help that we could biopsy, because the lesion might give us the answer in this case, or at least a lot of good information.
Thanks so much, AMK. And then I see Nikita mentioning the really important point about sort of how we might get to the diagnosis of Behçet's, which has been mentioned a number of times very appropriately given the findings of these various mucosal ulcers. Nikita, are you in a place to unmute and share a little bit more about sort of how you how Behçet's is fitting into your formulation of the case?
Yeah, hello. I think it could be one of the diagnoses, just because a few points that I think we missed out in discussing was the back pain, the pain in defecation, and a few of the mucocutaneous manifestations are aligned to Behçet's, but then the picture showed ulcers, and as far as I know, Behçet's shows an erythema nodosum picture. So I wasn't really sure whether it would fit into the picture of Behçet's, but there aren't any labs or imaging that proves one or the other diagnosis. So I'm considering a chronic inflammatory state, which would sort of be what Behçet would prove. So yeah, that was my thinking behind that.
Thank you so much. Thank you so much. Fantastic thoughts. All right. Well, Gabrielle, why don't you go ahead and take us forward? And I'm very curious to see kind of how these things unfold, particularly with how the chronic sinusitis weighs into this, because I think that is sometimes a buzzword for some of our ANCA-associated vasculitides that can often have upper respiratory tract involvement. But I feel like I just don't necessarily know whether or not some of the other vasculitides we're talking about, like Behçet and PAN, or some of these infections, I don't have a sense of how compatible chronic sinusitis might be with those diagnoses. So I think those findings are sort of making the small vessel vasculitis hypothesis go up higher and higher. But again, that's more due to comfort with one of those disease processes and discomfort with the other ones mentioned here.
Yeah, as also many folks in the chat are asking if there's a skin biopsy because tissue is key. And so the skin biopsy showed neutrophil perivascular infiltrate and fibrinoid necrosis compatible with what is called leukocytoclastic vasculitis. And then I will give the final diagnosis if maybe there's some final thoughts.
I would say I always struggle with the finding of a leukocytoclastic vasculitis because it can mean so many different things. I think given the diagnoses we've been considering here, it may increase the diagnostic weight behind something like a small vessel vasculitis. I think some of the other disease processes we were thinking about, for example, something like disseminated TB or a disseminated fungal infection, I would usually expect those to have granulomatous inflammation of the skin, and we may see something like a paniculitis on skin biopsy. So this may be more compatible with something like a small vessel vasculitis. And then some of the other disease processes that we've been talking about, things like disseminated HSV or VZV. Normally, my sort of like mental model is that when we take skins, or when we take samples from an organ that's involved, we can usually see viral inclusions on those skin samples, or I should say on those biopsy specimens. I don't know if that's the case for something like the skin, but certainly it is the case for something like the GI tract if we might see CMV, for example, in those areas. And I think, so maybe the absence of viral inclusions, the absence of granulomas, and the absence of paniculitis increases the weight for the vasculitis category. But I think in that case, then we're still sort of left grappling between small vessel, medium vessel, and some of these variable vessel diseases like Behçet. But I think the overwhelming number of findings that we see here, skin involvement, kidney involvement, pulmonary involvement, an indolent course characterized by inflammation and sinusitis, it seems compatible with one of the ANCA-associated vasculitides, acknowledging that there's so much overlap in these syndromes that it can be difficult to make a final diagnosis just without the specific antibody testing.
Yeah, you're right. So the ANCA was positive, and the PR3 antibody also was positive, 34.2. So that makes a final diagnosis of GPA. And so for what I learned about this case is that GPA can have two presentations: a limited form that includes the upper airway symptoms, and sometimes it relapses, and the ANCA sometimes is not positive, and it is positive in 50 to 80% of the patients. And the physiopathology behind is a Th1 response. But sometimes GPA can have a systemic manifestation that involves a kidney, the skin, musculoskeletal system, gastrointestinal, cardiovascular, etc. And in that case, the ANCA is positive in more than 90% of the patients, and the physiopathology behind is a Th2 predominance. So if it's Th2 predominance, we don't see granulomas in biopsy. That sometimes is very common in GPA. So yeah, that was the final diagnosis.
Thanks so much, Gabrielle. This is an incredibly fascinating case, and I think one that really highlights the variable presentations of this disease that we may see. I think a number of people are highlighting in the chat the fact that these severe mucocutaneous findings maybe don't necessarily characteristically match our illness script for this disease, knowing how much expertise you've built in the particularly in the derm space. I'm curious if you learned anything in particular about sort of how common or rare oral ulcers or rectal ulcers may be in a disease like GPA.
I don't know how much common they are, but some common manifestations of the skin involves oral ulcers, and also we can see purpura, digital infarcts, sometimes gangrene of the digital parts of the body. And in the biopsy, it's sometimes found leukocytoplastic vasculitis, but I don't know how much common is that, but given the shift complaint of disseminated ulcers, at first we thought that this could be, for example, some infections causes such as someone mentioned it, for example, disseminated TB that can also compromise the mucocutaneous system, or for example, cytomegalovirus. Sometimes HIV can induce this. For example, that oral ulcers in the mouth. Maybe this could be mucocutaneous ulcers of Epstein-Barr, or also a cutaneous lymphoma, because the patient has a very systemic inflammation. So that those were kind of the differential. Oh, and I forgot, of course, Bisset disease.
Awesome. Thank you so much, Gabrielle. And I see this really excellent question from Angelita in the chat about how we potentially integrate the odynophagia and the hoarseness into the process. And I would say that there are a number of ways by which a disease like GPA can cause both odynophagia and hoarseness. We oftentimes learn about respiratory tract involvement in GPA through the lens of the pulmonary parenchyma. We learn about things like nodules, which we saw here, as well as sometimes we can have cavitary lesions in the setting of GPA. But there's also a large amount of upper respiratory tract involvement that can happen in GPA. For example, these individuals can have tracheal stenosis. They can have a chronic laryngitis as well. And sometimes the vasculitis itself, right? Many of the common organs that we think about that are filled with lots of small vessels, the lungs, the kidneys, and the skin, but there's also the nervous system that can be involved there. And so you can occasionally have a neuritis of the recurrent laryngeal nerve, which can also contribute to hoarseness. So the hoarseness in the setting of GPA can be related to direct irritation of the larynx, a sort of chronic laryngitis. It could be related to upper respiratory tract morphologic changes like tracheal or laryngeal stenosis. And then rarely you can have recurrent laryngeal nerve involvement from a vasculitis. The odynophagia, I suspect in this case, was related to the underlying extensive mucosal disease that we saw, with the oropharynx being the tip of the iceberg, but it's completely plausible that we had ulcerative lesions extending down through the GI tract, including involving the rectum as well. I also wanted to just give a huge shout out to this entire group who was on here. I think it's really remarkable that from the beginning of this case, when Gabrielle gave us the HPI, so many of individuals here were able to characterize this syndrome as one that was suggestive of vasculitis. And I think that really triggered the framework that AMK shared with us of is this a vasculitis or is this a vasculitis mimic? And because that really ended up being the two diagnostic pathways that we went down. We thought about the various vasculitides, but then also thought about the mimics of them, which oftentimes settle on disseminated mycobacterial, fungal, or certain specific bacterial infections as well. And so this group, as always, was on the scent of the case. And then the last reflection is just how there's oftentimes these findings that we think carry a lot of diagnostic weight, that when we really look at the ways that cases unfold, it may not always be the case. I have learned and heard a number of times that when you see tree and bud opacities, it equals infection. But I think in this case, what we can take home is that tree and bud opacities may suggest infection. However, when we take the whole constellation of this case into perspective, the tree and bud opacities really make or the tree and bud opacities are just one piece of the larger puzzle here, which suggests a non-infectious inflammatory process. And so I think this group did an unbelievable job getting to the final diagnosis. And I just want to say a huge thank you to everybody who shared their thoughts. Those of you who joined us for the first, second, or third time, welcome to VMR. And we really hope that we get to have you back again. And I will turn it over to Sammy now to take us home with what looks like a action-packed set of teaching points.
Yeah, thank you, Jack, and thank you so much for this amazing case, Gabriel. Your cases never cease to amaze me, and I learned a lot, and also the chat was on fire, and I think we all had a great session, so thank you everyone who participated. I will just go over some quick teaching points. First, we started approaching a multi-system disease, and we have to think broadly. We have to consider disseminated cancers or infections, but also autoimmune disease, for example, vasculitides, connective tissue diseases, or arthritis, and always get an HIV test. Then we had these mucocutaneous disseminated ulcers, and we thought of infections, especially HIV, syphilis, HSV, endemic fungi, TB, and non-tuberculous mycobacteria. Also autoimmune diseases, for example, IBDs, Behçet's, pemphigus vulgaris, and also vasculitis. But it's also important to think of drug reactions, especially Stevens-Johnson syndrome and the maximum form toxic epidermal necrolysis, and also erythema exudativum multiforme, and also consider cancers. And then Jack taught us this great teaching point that whenever we see we see someone with a history of latent TB or active TB which was treated, we should always consider recurrence of disease, because TB can hide in a lot of spots, and we also have to check compliance and just always consider it. Then we had this finding of, or this history of bronchiectasis, which I learned from the Palm Peeps podcast. You can actually localize, and this makes certain diseases more probable. For example, when you have central bronchiectasis, we always think of ABPA and HIV. Upper lobe prioritizes cystic fibrosis or sarcoid. Middle lobe, think of ABPA and MAC. Lower lobe, especially aspiration, alpha-1 antitrypsin deficiency, HIV, primary ciliary dyskinesia, hypogammaglobulinemia, and rheumatologic diseases. Then we had this finding of the wide pulse pressure, in which we should always think of aortic regurgitation and arteriosclerosis, but also causes of high output states, for example, anemia, sepsis, cirrhosis, AV malformations, thyrotoxicosis, thiamine deficiency, pregnancy, myeloproliferative neoplasms, and also Paget's disease. Then Jack taught us that UA can be normal in glomerulonephritis. And I remember Robbie saying once that when you get a UA, you always look at the urine and then look away. So you should never disregard a normal result and always trend it when the pretest probability is high. Then we had this finding of tree in bud appearance, and which basically means that the bronchioli are filled with molecules, which prioritizes, as Jack taught us, infections, especially bacteria, virus, fungi, mycobacteria, but can also happen in aspiration, ABPA, connective tissue diseases, and as we learned today, also in vasculitis. Then we discussed glomerulonephritis, which we can divide into hypocomplementemic and normal complementemic. For the hypocomplementemic, we should always think about SLE, MPGN, SPARA, or post-infectious glomerulonephritis, and also cholesterol emboli. And for the normal complementemic variant, ANCA-associated vasculitis, anti-GBM disease, IgA nephropathy, or IgA vasculitis. And lastly, we had this finding of leukocytoclastic vasculitis. Type 1 thinking should always make us prioritize small vessel vasculitis, for example, GPA, EGPA, or MPA, but don't forget that also infections and malignancies can cause leukocytoclastic vasculitis. So yeah, that's it. Thank you everyone who participated.
Woo! Thank you so much, Sammy. Thank you for summarizing that case brilliantly. Another huge thank you to Gabrielle for bringing a phenomenal case today. I learned so much from this case, from this whole group, and I'm going to have to download the chat because I think that there are probably a million pearls that I missed along the way that warrant a lot of education. And finally, I want to give a huge thank you to Shema for scribing this morning. There was a massive wall of data to get on the board, and you did it flawlessly as always. But yeah, thanks everybody. I hope you all have a great rest of your day, rest of your afternoon, rest of your evening, wherever you are. And I had a great time with you all this morning and look forward to seeing you again soon. Thanks so much. Have a good one.
Bye.